All right, Chapter 38, Preventing Wound Care and Treating Pressure Ulcers. Okay, different types of wounds. This is out of your book. These are vocab. You do need to learn the difference between the type, as well as the closed and the open. And something to consider is which of these two categories has the highest risk for infection. It's going to be the open. So you need to take this into account when you're assessing your patient, as well as you need to use the correct terms when you're documenting your wound assessment. So please learn the vocab out of the book. There are different phases of wound healing. Regardless of the cause and the type of wound itself, there are 3 phases of wound healing: inflammatory phase, proliferation, and maturation. Please review that in your book. This is a review from 104. So if you don't remember the phases, please review them. Phases of wound healing. So healing by first intention is going to be there's very little tissue loss. So the edges of the wound close up. They come together, which is that approximate. This is only a slight chance of infection. Second intention is wound with tissue loss. So the edges don't approximate, they don't come together. The wound is left open and filled with scar tissue. So if you have a cut and you go to the emergency room, and sometimes they give you stitches and sometimes they don't, it has to do with the amount of tissue loss, if they can pull it together and create that approximation or not. Wound healing by third intention is when it's a delay of suturing a wound and they suture it after tissue begins to form. Very often they do this if there's an infection. They want the infection to go away, then they'll put it together and suture it later on. Factors affecting wound healing. So we have age, any type of impaired blood flow, because we talked about blood carries the healing properties to the wound. So if there's no blood flow to the wound, decreased healing. So anything like PVD or circulation issues, decreased immune system function. So now the blood is not up to par with the healing process itself. Reduced liver function. Liver synthesizes blood factors, so if the liver is not working well, now we have reduced immune function, in essence, is what's happening. Decreased lung function, you have to have oxygen to heal wounds. Nutrition, the big one we talked about with wound healing is proteins, but you do need an entire healthy nutritional status in general, but protein is the big one you absolutely have to have if you're trying to heal tissue due to the amino acids. Also lifestyle, so smoking, alcohol, exercise, the overall wellness of the patient is going to affect wound healing as well. Certain medications, steroids and other anti-inflammatories, it's stopping the inflammation process, which means we want that inflammation process for the healing, so the blood goes to the area. So if we're stopping that, we're actually decreasing their immune system as well as their healing process. Infections, so wound infections also are going to slow the healing process. Chronic illnesses, again, may slow the healing as well. Complications of wounds, hemorrhaging, we know what hemorrhaging is. Review your signs and symptoms of hemorrhage or hypovolemic shock. Make sure you memorize these symptoms. These are going to be coming up all the time. Some other wound complications are infection. The wound could be infected during surgery or after surgery. Also, if it was a traumatic wound or an open wound prior, that could have been when the infection was. Don't forget about your wound assessment, the words you're using, the purulent drainage, you're describing what you see, and review how to take a wound culture, when you're doing the wound culture, so is it before or after the antibiotic? Here's a picture of the obtaining of a wound culture. Notice the tops on the culture itself are keeping that sterile to not introduce any further bacteria. I believe wound culture is in chapter 24 to review how to collect one of those. Cellulitis is inflammation of tissue surrounding the wound. This is characterized by redness and induration. It also heat. You'll feel it be very warm. It's usually painful. Usually end up having to take antibiotics for this. Fistula is a abnormal passage between two organs or an internal organ or the body surface. This can be intentional, and in what we're talking about here is unintentional. Sinus is a canal or passageway leading to an abscess. All right, wound complications, dehiscence. This is the opening of an incision. A sign of this may be increased flow of serosanguinous drainage. Evisceration is the actual protrusion of an internal organ through an incision. This is serious. This is a medical emergency. Next slide is going to go into our care of it. So if an evisceration occurs, usually the patient's going to say, I feel something like go. They may not say anything, but that's usually the feeling that they feel. The patient should go in supine position, place a large sterile dressing over the area, soak it in sterile normal saline, and notify the surgeon immediately. You should not leave the patient's side. Someone else is going to have to notify the surgeon. Patient should not be left. Prepare the patient to return to surgery. Keep them on PO. So any type of question with this situation, you have to see where the patient is. So if they're standing, first thing you're doing is putting them supine. If they're in low Fowlers, first thing you're doing is getting that dressing on there. Which phase of healing begins on the 3rd or 4th day after the injury and lasts from 2 to 3 weeks? Answer is proliferation phase. The first phase is known as the inflammatory, the second one's the proliferation, and then the maturation is the last stage. It happens about 3 weeks after the injury. So question 2, which is not a factor in wound healing. The answer is type of wound. The type of wound doesn't matter. It's still going to go through those phases. The other 3 are going to affect the wound healing itself. Different type of wound closures, sutures, staples, wire clips, large retention sutures look like these big plastic things, Steri-Strips if the wound's small, and then Dermabond is a non-invasive glue. And when you're doing your wound assessment, you would count the sutures, the staples, any of these, and they would be in your documentation, as well as what everything looks like. Drains and drainage devices, they are an exit for blood and fluids that accumulate during that inflammatory process. They could be active or passive. So passive would be like a Penrose drain, which is just a flat rubber tube that allows the drainage to flow out. It could also be using vacuum, so Hemovac or a Jackson-Pratt. That's the Penrose drain. This is just passive. It's just allowing the fluid to come out. Then we have the Hemovac. This is like an accordion. It's going to be pushed down, similar to a Jackson-Pratt, and secure. And then that vacuum, that pressure change, the negative pressure, the fluid's going to flow towards the negative pressure from positive to negative. Here's the Jackson-Pratt. You're going to squeeze the bulb and then secure it. You always want to make sure that bulb is squeezed. Lots of different reasons for dressings. There are protective coverings over wounds. Watch your orders. Your orders are going to tell you how the wound is to be dressed. Lots of different types of dressing materials. Follow your orders. There's new technology and new types of dressings all the time. So always consult wound nurses. If you don't know, or the physician may order you something specific. Treatment of wounds. So the wounds are usually cleansed with a warmed isotonic saline. The doctor may order antibiotic solution. If surgical and open wounds require sterile technique, you may not see it that way, but technically surgical wounds and open wounds need sterile technique. Also, we'll go into this in the next slide, but a wet to dry dressing is a type of debridement, a mechanical debridement. So there's a specific way you're supposed to remove the wet to dry dressing. So debridement is removing necrotic tissue from a wound so the healing can occur. The doctor may do it with scissors and forceps. It may be an enzyme like Santal, where the enzyme liquefies dead tissue. Also, it could be mechanical, which would be through water whirlpool treatments, or a wet to dry dressing. So with the wet to dry dressing, you you guys learned the skill to put the moist gauze in there. When it dries, you are supposed to pull off that dressing. Some sources say you can put a little bit of saline on it, but really, unless it's really stuck on there, you're pulling it off. Now, you do have to use your judgment, because I have seen some of these that are so stuck on there, you're going to be ripping off layers of tissue. So in that case, you may want to moisten it a little bit, but in theory, it's supposed to be just dry and you pull it off. So that's that mechanical debridement. Different types of dressing and securement. That is also going to depend on where the wound is. So you may use like a Curlex, that stretch gauze around an arm, but you can't really use it around the stomach. So you need to keep in mind where that wound is. So here's a picture of an abdominal binder after surgery. We talked back in the other chapter about pain. The point of an abdominal binder is to support those internal tissues for pain relief. Now, you may see them to hold the dressing on, but that's not technically the purpose of it. The original purpose for pain management is to support the soft internal tissues. Tape application. The big thing with this is make sure your patient's not allergic to tape. I've seen skin fall off because of the severe allergies to the adhesive portion of the tape. So make sure your tape's long and wide enough. Make sure the dressing is completely taped on the way it should be. Suture removal. Sutures are often removed by the physician, not always. There is a picture on how you should remove the sutures, but this is sterile technique. If you're removing staples, there's a special instrument that kind of gets hooked in it and pulls them up. Steri-Strips may be applied after the removal of sutures or staples. Anything left under the skin may cause inflammation and infection and problems healing and scarring. So you have to make sure you're removing these correctly. So here's how you remove sutures. So you're clipping in one spot and you're using the knot to pull out. So you get the entire suture. If it's stuck to the skin, you don't be jerking on it. Come back later and see if we can get it a little loose. If not, you may have to inform the doctor. Here's a picture on staple removing on that little tool that you use to pull up the staple. Here are Steri-Strips applying after suture removal. Here's a picture of a wound vac. This is not technically on. This black foam would be sucked in down into the skin. But with the wound vac, your role is going to be changing the dressing, as well as making sure the wound vac set to the physician's orders for the pressure. The settings are correct, and assessing the drainage and how much, as well as assessing the wound when you change the dressing. Here's a picture of wound irrigation. It's sterile. Should be a warmed, like an isotonic solution on there. So a warmed saline. Doctor may order you something with a medication in it, though. Here's a list of nursing diagnoses for patients with wounds you can look over, and this will help you with your care planning and concept mapping later on. Here's some examples of goals that relate back to that slide with the nursing diagnoses. Question 4, Eric is about to change a dressing on his patient. Which of the following is true regarding dressing changes? The answer is 4. Wounds should be cleaned with warm saline. So you have to have a physician's order to change a dressing, especially that first dressing. We're not reinforcing. We would not be changing it without an order. If there's drainage on that first dressing, you're marking the drainage with a pen, dating, time, and initial. But anything that would need change, you would have to call the doctor and either have an order for it, or the doctor would come change the first dressing. Irrigations need a doctor's order as well, and it's sterile procedure. And here's a trivia question. So cold compress therapy, how long can cold compress be applied for? Answer is 20 minutes, and please review about the temperature therapies back in the pain chapter, the hot and the cold, who cannot get it when it's contraindicated. Cold sometimes causes spasms, which means you wouldn't be using them on patients if it is causing spasms. So that's the end of this chapter. Thank you very much for listening.